Hi everyone, my name is Andrew Burwood. I'm a partner at Larking Gowen, and welcome to today's episode. I'm really pleased to say that I'm joined today by Rob Day from Mills and Reeve. Hi Rob,
Hi everyone.
and today we'll be covering off contract changes and neighbourhood health developments.
Yep, thanks, Andrew. Yeah, so this session really is a supplemental session to a live event that we did yesterday in our Norwich office. So it can be watched at a later date for those that were unable to attend and wanted to then look back at what we covered off because it is all very important and very topical. So you ready to crack on, Andrew?
Yes, let's do it.
Right, okay. So what we're going to be covering today is a few different things. So Andrew's going to talk us through the contract changes that have been announced and where we expect to be in relation to the Carhill update. I will then cover off the Neighbourhood Health Framework, which I'm sure many of you listening to this will know was released last week. We'll then talk around next steps, and we've got Q&A there. Obviously, this was from yesterday, but what we'll probably do is just touch on some of the questions and answers that arose from yesterday's session, because it was quite a good and in-depth discussion around what needs to happen going forward. So over to you, Andrew, if you want to kick things off.
Yes, please. Thank you, Rob. So we are kicking off with the changes to the global sum, which will come into effect from the 1st of April 2026. For the 25-26 year, GMS practices were paid £123.34 per weighted patient. I'll come on to what a weighted patient is in due course. That amount is increasing to £128.69 from the 1st of April. So that's an increase of £5.35. However, £1.28 of that is coming from the Retired Advice and Guidance Directed Enhanced Service, which some of you will be aware amounted to £20 per pre-referral request in 25-26. Therefore, if we exclude that, the net uplift to your global sum per weighted patient per annum is £4.07, which is a rather miserly 3.3%. On the slide now, there is just a brief reminder as to how global sum is paid to practices based on weighted numbers. It's based on a quarterly basis. Quarters start on the 1st of April, 1st of July, 1st of October, and the 1st of January, and weighted patient numbers are run on the 1st of each day of that quarter. So if you have any new patient registrations, the key tip to make sure is that they are registered before we get to the end of a quarter. Otherwise, you're then waiting for a subsequent quarter to start receiving payments for them. How the numbers work, you'll see in this instance that the practice has a registered list size of 17,622. Weighted patient numbers for this practice are 18,113. That figure is multiplied by the new global sum per patient of £128.69 to give you a global sum for the year of 2,330,972. That figure is then divided by 12 to give you a monthly payment of £194,248 for the next 3 months. So that would be April, May, and June. And then the position is reconsidered on the 1st of July and so on and so forth. So that's what we know so far insofar as GMS rates are concerned. As far as PMS are concerned, those rates will be confirmed in due course, but it should be that the increase of £4.07 will be mirrored within PMS and APMS contracts. Okay, so next point we know is the charge for opting out of providing out-of-hours services. Since the new contract came in way back in 2004, there has been a deduction for GP practices who are no longer providing out-of-hours services. The rate since 21-22 has been 4.75% of the global sum and temporary patients added together. That figure is being reduced to 4.7% from the 1st of April 2026. It will still mean an increase in the charge though, because the global sum has gone up. Therefore, the amount that you pay for opting out of providing out-of-hours services will also go up. Next point to note is the weight management DES, previously paid at £11.50 per referral. That has been retired and has been moved into the quality and outcomes framework, and that is worth 5 points within that framework. We'll come on to other QOF changes on a subsequent slide. And then also to note is that maternity, paternity, adoption, and sickness allowance rates are increasing. On the third bullet point on your screen, you'll see that the numbers are actually the wrong way round. It should say going up from £1,418 up to £1,475. but the subsequent amounts are correct. In both scenarios, those increases are equal to 4%, and those figures are the new rates claimable again from the 1st of April 2026. We are now looking at ARRS changes. So for employing GPs under ARRS, that's the Additional Roles Reimbursement Scheme, the rates are increasing to 114,000, and on cost, so that's the employer pension contributions and the employer national insurance contributions, they can be claimed on top of the 114,000 that is available. Now, that figure is subject to DDRB recommendations. We normally see those recommendations coming out in the summertime, but we are led to believe that they could be sooner this time around, even as early as next month. So we will have to wait and see what those changes are. The restriction, and this is a really key point, and it is going to be beneficial, the restriction limiting GP recruitment to recently qualified GPs, that has now been removed. So you are able to recruit under ARRS GPs with experience and not having to worry about that 2-year barrier that was there before. Total ARRS funding is increasing to 1.764 billion. That's another 2.5% increase. However, that is below the 3.3% that the government has announced and agreed for AFC Agenda for Change. Again, we await details of the DDRB report to see if that figure is increased further. Another key point to note is that the capacity and access payment of £4.58, which is paid to PCNs, that money is now going to be moved into general practice, into your core contracts, to fund a new GP reimbursement scheme to recruit extra GPs or increase sessions to support same-day urgent access. We don't know the full detail as to how those claims will be made as yet, so that's very much a watch this space. But the key note to take away is the wording there in bold, and that is that same-day urgent access is now a binding contractual obligation. So the funding is there, and you are going to have to make best use of it as you can. However, that's a challenge given that the money that was previously going to the PCN for capacity and access, that has already been used by PCNs for providing or supporting provision within general practice. So that could be a challenge moving forwards.
It's probably worth saying, Andrew, we had a question at this point yesterday, didn't we, around new GPs, and it was around the baseline, whether a baseline would apply in connection. And the answer to that is we anticipate that the baseline will be set. It's just we're not 100% clear as to when the date on which that baseline will apply from. So it's not, as was suggested as a possibility yesterday, that suddenly I can employ my existing GPs via this scheme. That won't be the case. There will be a baseline that will apply. It's just we need to find out when that date will actually apply from.
And if we go back to the ARRS scheme when it first came in, it was all very much around additionality, wasn't it, Rob?
Yeah, 100%. Yeah, 100%. Now, I'm not clear whether the baseline will be set as far back as 2019, which is when the first baselines were set. That would seem quite unfair, but certainly some baseline will inevitably apply because the concept of additionality is going to equally apply to the GPs here.
Okay, so next point to note is the Quality and Outcomes Framework. You will see that the points for 21-22 and onwards, there's a summary there on the slide. For 26-27, there has been an increase or a proposed increase of 18 points to take it up to 582 in total. Now, 5 of those are coming from the retired weight management DES that we previously mentioned. There are 13 additional points for shared decision making and pharmacotherapy. The other point to note, and we haven't got the details on the slide, but you'll be able to see this on the contract pages of primary care and GP contracting on the NHS England site. But there have been several indicators that have been retired and they have been replaced with consolidated versions. The next section of that slide looks at the value of each point in terms of monetary value. Now, you'll see for 26-27, they have announced that the value per point is going up to £227.95. This is quite frustrating for me. It's something that I do find quite annoying, I have to say. It looks as if the value per point is going up, but all it is doing is matching the increase in the average list size across the country. But beside each of those figures, you will see that over a period of time, yes, the value per point has gone up, but so too is the average list size. So doing the numbers, the percentages in increasing one, increasing the other, they are always the same. So whilst they have not confirmed the average list size for the country for this year, the expectation is it will be 10,295. So if your practice has a relatively static list size, in other words, patient numbers aren't keeping pace with the national averages, it does mean that the value that you will get from the QoF regime is actually starting to shrink. If your list size is increasing in excess of the national average increases, then the value will increase in terms of monetary value for your own practice. The other point to note is that the aspiration payments you get on a monthly basis for QoF achievement are based upon 80% of the previous year's total achievement. The remaining 20%, once your points are confirmed at the end of the year, will come in around April, May time. Okay, so Rob did mention that we would talk about the Cahill update. This is where we are now going to talk about it. So Cahill formula, Professor Cahill developed the formula and it was introduced with the new contract back on 1st of April 2004. It wasn't fit for purpose then. It absolutely is not fit for purpose now. So there has been much talk about a need for a revised mechanism to work out how practices should be paid for their patients on their list size. Coming back to what is weighting, weighting calculates basically the value of a patient at each practice based upon the criteria that you can see on your screen. University practices tend to lose out under the Cahill formula because if you think about those practices, the patients that are registered with them are young, fit, healthy, very rarely present themselves to GPs requesting any assistance. So it follows that the funding they get is much less than what a typical practice would get. The formula itself was subject to a 6-month review. That completed on the 8th of March 2026. The anticipation now is that a new formula will be introduced with effect from 1st of April 2027, but we will have to wait and see if that is achievable or not. I think the speculation is that may be ambitious, but that's the proposal at this particular point in time. The bottom point was a note made by Stephen Kinnock, Primary Care Minister, in parliamentary session. You'll see that he says it should be based on need, but it was based on very outdated statistics and data. We are fixing that. An updated formula will have a complex range of drivers in it based on remoteness and coastal areas, but social economic indicators will be very much at its heart. So we were hoping for a change sooner than this. The GP contract itself was 20 years old at the end of March 2024. There should have been a new contract issued at that particular point in time, but we've been through a change of government. We've now had the publication of the NHS 10-year plan, which we'll come on to with the neighbourhoods and everything else. So very much the contractual funding mechanism, it's well overdue. We sincerely hope that it's changed for the better with effect from April next year.
Right, it's over to me. So moving now on to the Neighbourhood Health Framework. So as we did yesterday, it's probably worth saying that this framework was promised, I think it was October last year, I believe, Andrew, and it's been pushed back and back and back. So the framework itself was going to set more colour around the expectations and potential obligations when it comes to the delivery of the new Neighbourhood Health Service, which was established as part of the 10-year health plan, which I'm sure anybody listening to this will be very much aware of the detail. Just being clear and just taking a step back before we look at the detail of the framework itself, the headline points on the 10-year plan are these 3 big shifts. So there is an ambition to shift, and this is shift number 1, hospital to community. So this moving care away from hospitals into the community setting. Shift number 2 is to move away from sickness and more towards prevention. And shift number 3 there is moving away from analog to digital. So a big part of those, and in particular the shift number 1, was the creation of that Neighbourhood Health Service. So that's the background as to why we're talking about it now. So in connection with that service, the framework was released. Now, if anybody's had the opportunity to read it, well done. My initial reading of the framework is that it was quite confusing, certainly initially, because it referenced aims, goals, objectives in various different areas. So it was quite difficult to follow, certainly who would be picking up what and actually what the overarching ambitions are. But if we strip it back and if we read it through a few times, it's clear that we have 4 overarching aims when it comes to that neighbourhood health service. And they are articulated in the framework to cut waste and duplication, to reduce pressure on acute services, to improve health outcomes, reduce health inequalities, and help people stay well at home. And lastly, the final aim is to organise services around the person with more convenient, personalised care. Now, in connection with those aims, it's for the locality to decide what the vision and commissioning arrangements are going to be to realise those aims. But when we talk about that system, we're not just talking about traditional NHS providers, as you would expect. We are talking about a number of different players within that system. So those working in traditional NHS settings, roles, local authorities, private sector partners, to name but a few. But effectively, they will need to come together to agree what that vision looks like for the locality that they effectively serve. So they're the overarching aims. We then have goals. So whilst I won't go through the metrics, and it's quite good to know that there are actually metrics, not just ambitions and goals here. The framework sets out the 5 initial goals that will exist when it comes to the neighbourhood health service. Now, in connection with those goals, what I should say is those 5 goals are the ones that are going to be set nationally. So as we can envisage through the full life of this 10-year plan, there will be moving targets when it comes to nationally set goals that they want the systems in each area to deliver on. But they will be then supplemented by locally agreed goals as well. So there's a recognition, yes, there needs to be consistency across the country with nationally set goals, but there will also be the necessity for locally set goals as well to service what's required within specific localities. And it may be that those goals are then subdivided down into certain areas as well, depending on things such as deprivation and health inequalities. But what we've got is the first 5 goals will run between 2026 to 2029. That is a very short window for achieving or aiming to achieve these goals, particularly when we talk about the structural arrangements that are in place to enable these things to actually be delivered. But in any event, what are those goals? So the first one there is to improve health outcomes with specific focus on high priority cohorts. So those high priority cohorts are listed within the framework. It covers children and young, it covers cancer patients, it covers end of life, etc. So there's a specific list of high priority cohorts within the framework itself. Next point is around improving access. Our next goal there is improving access to general practice. So it's worth just highlighting what the metric is and what it's specified within the framework to be. So in connection with that, its metric or its goal is that general practice will see 90% of clinically urgent patients in the same day by March 2027, improve faster access for routine GP care, and new access data will be collated to set goals. So as you know, or as you'll be aware, there is a requirement to provide data around access into general practice, which they will be taking. The reason for them requiring that contractually is now clear. It's to feed into this key goal, which is arising under the Neighbourhood Health Service. And the last there is improving patient satisfaction. Goal number 3 is to improve experience of planned and cancer care. Goal number 4 is to improve urgent and emergency care. And goal number 5 is to improve patient and staff satisfaction. So we talked about it yesterday because I think there was a question that was asked around this as well. Is there's going to be an obligation, for instance, on primary care networks to ensure that staff that are employed under the R scheme, and that might not necessarily be staff that you directly employ. So even if you employ via a third party, you will need to pass that obligation on. to enable them to participate in staff surveys. But there is a big question, and one which was repeatedly talked through yesterday when we spoke in person about this with the various attendees, is where will these contractual goals actually sit? Now, at the moment, it's unclear at what level will they sit, who will take responsibility for this. Unfortunately, that level of detail is not there. We then come on to reforms. So we've got the aims, so the overall aims of the Neighbourhood Health Service. We then got the goals of what it's going to achieve in the next 3 years, and they will inevitably be varied as time marches on. We then have what they call intervention requirements for ICBs when it comes to reforms within areas to enable the goals to be achieved, but also the aims to be achieved as well. So there are 3 reforms which the ICB have effectively got to ensure take place. They are improved services for routine care. And as you'll see from the slide there, and I won't read out each one, there are then specific requirements that need to be put in place to achieve that specific reform. So that's the first reform. The next reform is to improve proactive care. So again, that then has specific requirements attached to that reform. So that includes the creation, and this again was something that was discussed in quite detail yesterday, the creation of new integrated neighbourhood teams to work across these different providers in order to achieve the joined up and community care that's expected. And the third reform there is creating better alternatives to hospital. Now, in connection with that, we're talking around things such as virtual wards. We're talking around the use of the NHS app, people having better self-care, those sorts of things. But the specifics that are attached to that are also linked and listed within the framework itself. So it's not a framework without detail. In terms of the reforms that are needed, it's a framework with reforms with specific targets that need to be put in place. Big question over this is around success, and I know a lot of events that I've certainly been to and a lot of discussion that I've seen is around, well, what does success look like when it comes to these things? And rightly so, a lot of people are saying the metrics that might be bandied around and used as a potential goal and a success or seen as a success shouldn't be considered in isolation. There are intangible successes that can arise as a result of this neighbourhood health service that will be equally important. But it will be interesting to see how success will be recorded and whether it will be softer in its approach as opposed to percentages or numbers of people seen within a specific time. The hope is it will be softer, because some of the best examples of patient care that we certainly heard yesterday and in previous sessions we've done are not necessarily driven by these numbers. They're driven by reference to subtle changes occurring in the delivery of care to individual patients. And that primarily seems to come about from teams working more closely together. Now, the next big thing within the framework, so that sets out sort of what's expected. It then goes on to give detail around the contractual and organisational form or reform, as I've potentially suggested in the slide there, that will take place. So at the top of the pyramid we'll have in this new way of working will be integrated health organisations. Now they will hold, or the anticipation and expectation is, they will hold integrated health contracts. Now these contracts are stated within the framework as contracts that can only ever be held by trusts, with the first trust being high-performing FTs. I mean, there's a lot of talk around the fact that a number of trusts and systems are in deficit and how could they possibly manage these sorts of contracts. But certainly the first trusts that are being lined up to be IHOs are in the top category, the high-performing category.
And I think, Rob, reading today, there are 5 that will be announced next month.
Yeah, yeah, absolutely. So we're already starting to see trusts gear up, certainly the high-performing trust, to take advantage of this. Well, I say take advantage of it. I don't know whether it's taking advantage or just gearing up to do what they're being asked to do, one or the other. But yeah, we're certainly starting to see that sort of play through now within the system. Now, whilst the contracts are stated within the framework as only ever being able or capable of being held by trusts, there is a reference within the framework that it could be led by mature neighbourhoods. So that's quite an interesting comment there. So whilst the contracts themselves couldn't be held by, for instance, a mature GP federation or a collaboration with different providers, it seems to suggest that by way of maybe a joint venture or a subcontracting type arrangement, that whole chunks of the requirements under the integrated health contracts could be moved down to a different organisation. So it's sort of one that's more potentially aligned within the community itself. Now, the contracts, as for the IHCs themselves, they will be big, big contracts. They're going to be whole population contracts, and they will create responsibility for resource allocation, the planning of services across the pathway, and the biggie, the left shift of services and, fingers crossed, funding away from secondary into primary. Big questions around how that's going to look and how that could operate. Now, one of the most fundamental points from the framework, though, to bear in mind, particularly if you're working within primary care, is the fact that IHOs are stated within the framework as being organisations that will be given delegated commissioning or responsibility by integrated care boards for primary care. So what that means is effectively, whereas now you have a situation where your ICB commissions primary care contracts, manages contracts. So if there's a problem, they'll serve breach notices, remedial notice, potential contract sanctions. That will be a responsibility of an IHO, as is suggested by the framework there. So big changes there. So the next rundown, we have multi-neighbourhood providers. So they will be providers that will oversee services across multiple neighbourhoods. Now, they will cover a patient population of around 250,000. But as we said yesterday when we did this live, clearly somebody's learned from the situation we had with primary care networks, where we had sort of quite rigidly set patient population requirements for PCNs. They've indicated that that number is not mandated. And if there is a genuine reason or sensible reason within the locality to flex that number, then that is fine. As to what flexibility exists or whether there'll be parameters remains to be seen, but certainly they've indicated they're not mandated. As for the type of entity organisations that can hold these contracts, so there'll be multi-neighbourhood provider contracts, they are not prescribed. So unlike the IHOs, where they've been explicit about the fact that they can only ever be held by trusts, that's not the case with MNP contracts. So they will be capable of being held, presumably, by any providers. So you could get trusts holding those, you could get alliances of made up of different component organizations within the system, you could get GP federations, the list goes on and on. But what we did discuss yesterday, and we've been saying for quite a number of months now since the release of the 10-year plan, is if there is a battleground around control of types of contracts, we envisage that this will be where the battleground really is. With so many different organisations having the ability to take advantage of these contracts, inevitably you're going to have a situation where there's going to be quite a high degree of competition to secure them. Now, whilst the detail of what the contract, and in fact any of these contracts, is actually going to require the providers to do, it's certainly implied that anybody holding an MNP contract will be required to look upwards and work with the trust to deliver on that left shift of service. But they will then also be looking to work downwards with single neighbourhood providers. So good segue then on to the SNP, single neighbourhood providers. So they will be required to provide services which are required in individual neighbourhoods where those services are not already covered by GP core contracts, so the GMS, PMS or APMS contracts. Rather spookily, you'd almost think they've been made to align with primary care networks. They will cover a patient population of circa 50,000. But again, it's stressed that these numbers are not mandated within the framework itself. But there is an expectation, and it's set within the framework, but that they must work closely with GP practices in their area to deliver the services which were required locally. And it's indicated that whilst it's going to be subject to further consultation, that it's certainly probable that primary care networks will evolve to become single neighbourhood providers. And that they will hold single neighbourhood contracts. Now, whether it's a big question mark at the moment. Is this going to be a brand new contract? Do we anticipate that actually we're looking at the network DES here that primary care networks hold that's just going to be supplemented with additional services and requirements? It remains to be seen. But I think the discussions yesterday and my personal views, I think, Andrew, you share these, is it would seem illogical to rip up the infrastructure that they've spent the best part of 5 years to put in place to create something new when it appears very clearly from all the goals and the time periods that are being set here that they have to achieve, measurable success and progress within a short period of time. So with that being the case, I think it's highly likely that we will see primary care networks lead on certainly this single neighbourhood provider work. And it seems, again, possible that it could be just an extension of the network DES.
And it makes complete sense, doesn't it, Rob? Been a direction of travel since 2019, the creation of entities working at scale, bringing providers closer together in the locality. It's in my mind, without doubt, PCNs will be the bedrock for what comes next with the SNPs.
Yeah, 100%. So talking around GP practices, as we did there, it's made clear, which is reassuring for those GP practices, GP providers, that they will continue to hold core contracts for the delivery of essential services. And probably more comforting is the fact that there is also specific reference. And I think this is probably referenced because there's all this talk around commissioning responsibility shifting out to IHOs. There is a reference within there that certain contracts will continue to be nationally set but commissioned locally, and those contracts are explicitly referenced to be NHS standard hospital contracts, GMS contracts, PMS contracts, and APMS contracts. So that's a promising statement that's made there. Effectively, they will still be subject to rules that are set nationally. And as we know, and whilst we have not got really the details of what it's looked like, certainly there is the new GB contract, which is under discussion and consultation. And we expect, or we hope, and again, this is another thing which was discussed yesterday because we're talking about the increase of liabilities here that might exist on practices if they're being asked to deliver more and employ more, that there will be certainly a relook, if you like, at the organizational sort of restrictions when it comes to who can and can't hold those core contracts. Specifically, and it always gets talked through, is around the possibility for limited liability partnerships to hold GMS contracts. But again, it remains to be seen. So diagrammatically, and this is lifted straight from the framework, this is how the pyramid will work. As you can see, in terms of the contracts, the organizations that will exist there. But there's an obvious question, and we're talking about it, loads about this. We're talking about a framework which relates to neighbourhood. We're talking about the Neighbourhood Health Service. We're talking about single neighbourhood providers and multi-neighbourhood providers. Well, the obvious question is, what is a neighbourhood? And there is no definitive description within the framework itself, but what they've indicated is that it will be for health and wellbeing boards to determine what that neighbourhood looks like within the locality. I imagine that we wouldn't be too far away from what the primary care network geography looks like, albeit there may be some flex if it needs to align more with community providers in some way, shape or form, which does create a bit of a headache because we may be looking at potentially disrupting membership within primary care networks and dealing with a shift around, which is never the easiest because you're asking people to work with people they might not necessarily have worked with before. But that remains to be seen. The framework then goes on to talk about other aspects, so more to do with the infrastructure. So again, if we sort of separate down what it does, it talks about the aims of the Neighbourhood Health service. It talks about what the initial goals will be in connection with the service delivery. It talks about the initial reforms that the ICB will need to make to establish and realise those goals. It talks about the contractual high level arrangements that will put in place with providers to deliver. It then talks about infrastructure, which is it certainly shouldn't be, and it's not a footnote. This is highly integral for the success of any neighbourhood health service, because without the infrastructure, you're just piling pressure on an already quite stretched infrastructure to deliver, which is not going to be fit for the purpose that it's intended to. So with infrastructure, the specifics there was we're talking about neighbourhood health centres, and I'm sure anyone listening to this knows and has heard about what neighbourhood health centres will be. Effectively, the anticipation will be that these will be multi-occupied or multi-occupational centres with various different providers operating from that locality. Now, in terms of numbers, there's a commitment there that there's going to be 250 of these neighbourhood health centres by 2035. And I should say the ambition is that every area will have a neighbourhood health centre that people can go to, sort of realise and receive this care in the community. Now, of those 250, and I should say of those 250, I was at pains to stress yesterday that this is not another 120 on top of that, but of the 250, 120 of those, there's a commitment to make sure that they're up and running by 2030. There is a statement that 20% of those will be funded by public capital. So we are going to see inevitably the emergence of public-private finance to help deliver on this ambition in terms of the infrastructure, state infrastructure. And it will be a mix of new and repurposed estate. Certainly the first wave, if you read the framework itself and any comms that have gone out around neighbourhood health services, centres, all of the first wave around these centres are in connection with NHSPS or NHS stock, so NHSPS to lift estate. So you can see already that they were looking to repurpose existing estate rather than build brand new. And I suspect that's more to do with the fact of getting maximum occupancy and use of estate which exists at the moment, but also for time. The speed at which they can get those up and running then is going to be far quicker. Now, I've already mentioned there about the fact it's going to be subject to multiple occupation by various different providers, and that does create headaches. Who's going to effectively take over the lead lease arrangement or property interest in these premises if you've got multiple providers that are in place. Now, it may be that we finally get to a point where actually there is an NHS body, if you like, that's taken the lead on this, be that an NHS trust, seeing as they're going to be ultimately holding the integrated health contracts that are in place. It may be that they take hold of the primary interest in the estate and then they sublet down to the various different providers that occupy there. But again, that remains to be seen, but it does need to be thought through carefully, because if you asked any primary care provider, do they want to hold the primary lease liability or property interest in these sorts of centres, I suspect the majority would say no. They don't want the risk and the liability that goes with that. Now, that's particularly the case if we start thinking around stuff such as service charges and the like. Next one around infrastructure is staff. A lot of this is only going to be delivered where the staff are in place to help it be delivered. And there is very little detail at the moment within the framework as to what that looks like, other than the fact that the 10-year workforce plan is being developed, and that there will be a new integrated neighbourhood team with new roles being added. Now, again, from discussions yesterday, it's highly likely, certainly at the single neighbourhood provider level, we're talking about the existing multidisciplinary teams that have been created within primary care networks, probably with some additions as well in connection with covering off some of the new obligations that are going to flow through. And the last point there is around broader infrastructure, and there's talk around things such as electronic patient records, AI, ambient voice recognition, those sorts of tools, albeit there is a big question mark as to whether these will be centrally procured and rolled out, whether they'll be locally procured, which is a big question, and is something I think we need to grapple with quite quickly, because otherwise you're going to get variations across the country, actual commitments that have been entered into, which will be very difficult to extract yourself from. So those discussions need to take place. And I think we'll probably end up in a situation as we have around the national goals. So there'll be probably a standard set of infrastructure that will be required, and that will be nationally set or nationally prescribed, and it will be for localities to enable providers within the locality to be able to use that. But then there will be flexibility to allow more localized IT and broader AI infrastructure that serves the purposes of the individual local provider. So concerns. So there are a number of concerns. Inevitably, there would be with these sorts of proposals. But these concerns come more from the lack of follow-on detail within the framework itself, in connection with, yes, we've got all this additional information, but still there is a lack of detail around some key areas. So not necessarily within the framework itself, and something which is talked through in any real detail, but should be, and that is there the capacity within the system at all levels to be able to deliver this? This doesn't happen overnight. It requires decent discussions amongst all providers, making sure they're all pulling together and creating something that's actually going to work long term. That takes time to do. And people are firefighting at all levels at the moment. Next concern is the integrated health organisations. They're going to be asked to deal with sort of requirements and obligations that be placed under obligations they never historically were required to do. So this commissioning responsibility for primary care, for instance, did they have the experience to be able to do that, the bandwidth to be able to do that? So there's a big question mark there. Who will enter into the contracts? The obvious point, yes, they're indicating the IHOs, but then everything else seems to be up in the air. So again, we need to sort of get very quickly around who is actually going to be entering into these contracts, so we can start to have discussions around providers organising themselves in readiness for the contracts to go live. It's no good announcing the contracts as to who's going to be able to enter into them last minute and expect everybody to suddenly organise themselves in a way that will enable them to take those contracts on. It's just not going to happen. There needs to be a decent run-in. Who will deliver what? Big question mark. It's unclear who's going to be required to deliver what at what level under this new neighbourhood health service. As part of that, who is accountable and legally responsible? We're asking multiple providers here to come together to deliver a service. well, of those multiple providers, who is actually going to be responsible if something goes wrong? Who's going to take charge of clinical oversight? These are not concerns that can't be overcome, but they need to be thought through carefully. But with that accountability and legal responsibility, then arises another concern of liability, which we've already talked about on today's session. But if you're asking traditional, for instance, primary care partnerships to take significantly increased liability here, that's a big ask when they haven't got that limited liability wrapper or the safety net that other providers would have. Massive point is funding. There is such a lack of detail in the framework about funding. That is the obvious concern. Yes, all the rhetoric is around that there will be a shift for a left shift in terms of service delivery and a left shift in terms of funding, but the detail of that is just not clear. Will we see the erosion of core businesses as a result of this? Core contracts for primary care providers will remain as is, but are we seeing actually anything else now? Any new money is going to be shifted elsewhere, which effectively means that you've got no option but to participate if you're a primary care provider in this additional work. Big one is, will we be marginalised? And this was something which was repeatedly discussed yesterday around this, and we'll come on to that. Do we need to change? Again, another big one that came up yesterday, which we'll come on to. And the last point then is a funding point as well, is will funding be ring-fenced? Yes, we're going to have whole population budgets being held by integrated health organisations, but will elements of the budget that they hold be ring-fenced? So, for instance, in terms of the budget for providing this neighbourhood health service, so the funding that's going to flow to the MNPs, to the single neighbourhood providers, and then to primary care, surely that's going to be ring fence. Otherwise, what you're going to have is a potential that just gets dipped into to cover off funding for other projects or other services at the trust level. And the other thing is, if there is a default, a failure, what we can't have is that this creeps through and affects the system as a whole. So some really big concerns there. And that just goes from the lack of detail that currently exists around the contractual arrangements that are in place and the funding arrangements that are in place. So next steps. So within the framework itself, and again, I won't go through this in detail, it's just to articulate the fact that really the framework ends with identifying what the next steps are. But really, these are steps more for the ICB on the commissioning side. It doesn't talk about what it expects the providers to do. So we talked yesterday around what our expectations are, and certainly those in the room that were providers themselves were talking around what they intend to happen. But if you look at the framework itself, it doesn't give that detail of what it expects providers to do. But from an ICB, it does. And what it does is it creates two stages. So steps and sort of, if you like, a KPI or a tick box that it needs to do in year 26 to 27. And then as a stage two, those things which need to happen between 27 and 29. So I won't go through those in the interest of time, but you can read those in your own leisure. But we then come on to the discussions we had yesterday and the things that we were sort of suggesting. Yes, there are concerns, but there are real opportunities. Somebody said, well, what are the opportunities? Well, there are new contracts available within the locality. And whilst the funding isn't clear at the moment, you anticipate that funding has to be made available for those providers to be able to deliver the service. So clearly there's an opportunity there. Secondly, there's an opportunity to work at scale with different providers. That has the opportunity to make the provision of services more efficient, which is only going to help all levels of the system itself. And lastly, and something which shouldn't be overlooked, is there's big opportunities here to improve patient care, and patients should be at the heart of everything that we're looking to do in connection with this service itself. Now, in terms of what you should be looking to do locally, certainly from a primary care perspective and a practice perspective, your primary care networks should really need to sort of start considering the organisational form that it takes if it has the role of morphing into a single neighbourhood provider. So what we're talking about here primarily is the possibility of incorporation. Some of you might have incorporated or discussed the possibility of incorporation. That needs to be on the agenda quickly. And we say that because it's not something that just happens overnight. Those discussions need to kick off, and the process needs to run its course. And we are probably talking at best a process that's around 3 months to deliver on, and that's if you're going at a rate of knots. So it does need to kick off if it hasn't already in terms of the discussions around organisational form. But that's at the SNP level. Let's not forget there's that MNP level, that battleground we talked about previously. And there is certainly the possibility, and we're in discussion with primary care networks around creating an umbrella organisation to create a vehicle through which an MNP contract, so the multi-neighbourhood provider contract, could be held. Similarly, there's GP federations that are considering their organisational form for them to be able to take advantage of multi-neighbourhood provider contracts. But again, those discussions need to kick off. Again, they don't happen overnight either. So these sorts of things do need to take place. The next point, and it's really just to be alive, be alive to changes that are taking place within the core contract and the discussions there. And be alive to discussions around provided collaboratives within your area. The big takeaway is discussions, and certainly from yesterday's sort of session that we run, discussions are absolutely key. If you're not in the room with the sort of decision makers when these things are being discussed, you have the very real risk of A, being marginalized, but B, something being imposed on you that you didn't expect or want. So being involved in those discussions and taking an active role in those is very, very important. I do think that we are probably at a point in time, which we've never seen before, that the different levels of the system will be open to those discussions. Certainly from the things we were hearing yesterday, is my experience as well. Trust now are far more open to the discussions around what it looks like, and they're actively looking to pursue the sort of arrangements and collaboratives that could be in place to help them deliver on what their obligations will be. So let's capitalize on that sort of goodwill, if you like, at this stage, and see if we can make sure that something is put in place that's actually going to work for you. Andrew, over to you.
Yes, thank you, Rob. So these next few slides, it's advice taken from NHS Confederation. If you look on their website, all of this is live documentation on there. It's a really detailed document. What I've tried to do in these slides is just pick out the key points to bring to you today, and certainly what we were talking about yesterday as well. So the very first point to note, it talks around with the SNPs, the population size around 50,000 patients, which again, bedrock of networks as they currently are. But the first bullet point, the text in bold is the key takeaway here. PCN footprints already provide a strong foundation for this approach. However, the majority of PCNs lack legal personality and therefore cannot hold neighbourhood contracts directly. And that's a really key point because, as Rob was talking about, the vast majority of primary care networks currently, they are loose collaborations between local practices. Typically, with the 30 to 1,000 list size bandings that we are talking about, you are looking at practices in number 3, 4, maybe 5, some as low as 2, but the average is 3, 4, 5. So you are working together to provide what is required to you or required by you under the network contract DES, but there's not a legal structure. The network as it stands, if you are that loose collaboration, you cannot hold a contract, nor can you bid for contracts either. So looking ahead, coming together within your networks, arranging meetings, talking about next steps, I don't think Rob or I can really overstate the importance of that, and it needs to be done as soon as possible. And certainly what we were talking about yesterday with everyone that was with us is, gosh, it's really hard to get people together to find the time when the pressure within primary care is so high. It's really difficult to come together and have those discussions. But If you don't do it, then it could be a lost opportunity. And as Rob said, you could find yourself in an imposed situation where you lose your voice. So that is really, really important. The next point talks about contracting jointly for neighbourhoods. There is a possibility that you inadvertently create a super partnership. So super partnership, you've probably heard the term, but a super partnership is where multiple partnerships come together and effectively form one single partnership. That is the definition of working at scale, but it loses that independence, that autonomy, that ability to make quick decisions. You may well have a partnership in that scenario where not all partners can have a say on the direction. You end up with effectively a board of directors in corporate speak that are making decisions for that partnership. So it will be completely different to what your typical 4, 5, 6, 7, 8 partnership currently looks like. So trying to avoid a situation which is not intended, again, is really key. But what the Confederation advises, it talks about three main contracting models. So we have the primary care-led model, we have a trust-led model, and then we have a joint venture model. And the next slide, Rob, if you'd be so kind, then breaks those down one by one. So what the Confederation have done quite helpfully is look at the strengths, the risks and limitations under each potential model, and also the best use and considerations for those. So I won't talk through these slides one by one. I'll leave them on the screen, or Rob will kindly leave them on the screen so you can have a quick glance through them. You can always hit pause if you're listening to this and just have a quick glance at them. But as I said, it's all on the Confederation website, and it's a really useful resource to look at. So this looks at the primary care model. The next one, Rob, is the trust-led model. I'll leave that there for a second. And then finally, we have the joint venture model. And this is probably where the MMPs are going to sit as well. So at this point, Rob, I think we were then going to move on to PCN incorporation, because having gone through the next steps and what is coming through the neighbourhood plans, we think that PCN incorporation is going to be the next step for you all to take. Rob, do you want to kick off on that next slide?
Yeah, absolutely. So this is just to say where this came from. So the session yesterday ended in the previous slides, but then there was a sort of addition. I mean, some of this is recapping, but for those that are seriously considering, it's worth touching on some of these points here. And we'll do it quickly. The sort of key points to note here is PCN incorporation usually means that you're sort of hiving everything up into a corporate entity. That's not what we're suggesting here. So PCN incorporation is a bit different. What we're talking about here is the constituent members of any primary care network create an umbrella organisation that will sit above them, and they will effectively own that organisation and work with it to deliver on certain services. So in this instance, under the network DES. Now, interesting, we've run this as a sort of PCN incorporation a number of times, and certainly as part of the Medics Money course that we sort of speak on. There are key questions that have been asked to us that have triggered discussions around incorporation. And what we both find quite interesting is those questions are actually probably the same. It's just we're now talking about an expansion around the number of staff you're likely to employ. Certainly, if suddenly we have this, new obligations flowing under a single neighbourhood provider, again, we can have increased liabilities. There's, bigger potential VAT problems that arise. And clearly there's the possibility for additional services here. So those questions that were always the case that triggered the discussions on PCN incorporation certainly exist now, but to a bigger extent. And you made the observation yesterday, Andrew, that there wasn't necessarily a big enough push to push people towards incorporation, but certainly as these sorts of discussions now and these sort of issues are becoming bigger, the push is even greater. And there were certainly discussions around yesterday around, okay, well, even if we just go through the process of incorporation, we can hold it there in readiness rather than necessarily setting up as a provider organisation with CQC registration, etc., which is a very valid point.
Yeah, and certainly, sorry, Rob, the obstacles and hurdles that have come about through networks coming into being in 2019 Yes, there were certain things that hadn't been considered when the network contract was rolled out really, really quickly. 1st of April 2019, it was pushed in, and basically you had until the 1st of July to get all of your ducks in order. We then had the issues over, well, there's VAT exposure because we're potentially supplying staff amongst member practices. We have, what else was there? Potential limitation of liability. We're working together when we haven't really worked together before. A whole raft of things to consider, employment status as a clinical director. But as we've gone along, most of those hurdles have been overcome without the need to incorporate, and there hasn't been enough impetus or drive to form a limited company. This is where the line in the sand comes. It's no longer the case that we can just carry on as we are. There has to be active change and active decision making to take it forward.
Yeah. So the next sort of point that we discuss, and we only touched on this very briefly yesterday, is, usually when we go into this type of session, we talk about it in detail. We're talking about the types of limited liability vehicle, which is effectively what we're talking about here, creating an organisation, umbrella organisation. We're creating a limited liability vehicle. But with all of this, and to save time, we always land on companies limited by shares. And there's a few very good reasons for that. And one of those is if the company itself is ever looking to hold a sort of a GMS contract, and it has to be a company limited by shares. But even then, there needs to be certain hoops you need to jump through in terms of legal and beneficial ownership of the shares, which is probably a bit much for today's sort of session. But the main point is we end up on that, landing on that type of vehicle. Pros and cons, we touched on this, and you can read that on the screen there. There are clearly pros and cons of incorporating and creating a limited liability vehicle. Probably the big one to sort of flag, and something which comes up on sort of numerous occasions, is this necessity for directors, and the fact that those directors have statutory codified obligations and duties. And that shouldn't be understated, because I think it does create a different mind shift, or a necessity for a different mind shift for people that are in a room discussing things which relate to the company. They have a duty to consider things which are in the best interests of the company, for the shareholders as a whole. Whereas shareholders, if they're taking a decision, can be quite self-interested as to how they vote on certain things. But have a look through those pros and cons. If you've got any queries, do get in touch with either Andrew or I. Main thing, and this is talking around this discussion point, for me, the real hope is that people that are not considering incorporation, or haven't before, do start considering it and start discussing some of the thornier considerations that need to be ticked off before you can incorporate. These are the things, in my experience, that can take time to resolve, because you're getting parties to agree on what's going to apply. So those specific considerations are priority of opportunity. So if Andrew and I are involved as practices within a limited company, what's the priority of opportunity if a new contract in the locality comes out for us to bid for? Will it be with us as individual practices, or will it be the limited company? There's no right or wrong answer with that. It just needs to be considered and thought through, and preferably documented. Restrictions on what practices can and can't do, that's becoming an increasingly important point here. So what I mean by that is the non-competition provisions that you would expect to see in contractual agreements, not to compete with each other, but more so around the non-solicitation as well, particularly with staff. What we don't want is a practice stealing the network staff and vice versa. So those sorts of non-solicitation provisions are coming quite important within the discussions around corporate vehicles. Guarantees and resource requirements, as we mentioned when we ran this yesterday, the expectation is very quickly that the limited company will be self-serving, but that's not going to happen immediately, and there's going to need to be some resource and capital requirements to get it up and running, and probably to run its first few months. When we talk about guarantees, be careful of guarantees. What we don't want to do is suddenly blow open the limited liability wrapper by offering some sort of unlimited guarantee from unincorporated partnerships. So just be careful there. Next point is around decision making. What decisions will be reserved for shareholders or practices, and those that will be reserved for the board to take. Again, no right or wrong answer, but just be cognizant of the necessity to agree how that looks. Then share rights. So when we talk about share rights, any company that's limited by shares will have shares, and those shares will have three rights attaching to them. They'll have voting rights, dividend rights, and capital rights, and they can vary. So I give an example. It could be a situation where voting rights are equal between all members of the company, but you have the financial rights, so the dividend and capital rights, linking to patient list size that could be varied year on year. There's no right or wrong answer there, but it needs to, again, just be thought through and agreed. Who can and can't hold shares? Are there going to be restrictions on other parties that might not necessarily be traditional GP practices holding shares? And that discussion is probably becoming more relevant because we're talking around the possibility of other providers being involved in the delivery of care. So it's certainly foreseeable that your corporate vehicles might have other interested parties being involved as shareholders. And then really, it's not necessarily just linked to pensions, and I'd add it to other aspects such as CQC as well. Don't overlook some of the more thornier, I say, organizational and operational requirements of what that company will need. Access to the pension scheme if it's going to employ staff, CQC registration if it's going to be providing a regulated activity, etc. All those things need to be considered, because if they are needed, there is a time frame for putting those in place. So in terms of the sort of initial steps that we see, and I should say that incorporating the company at Companies House is relatively straightforward. You can do it in 48 hours, do an online application to register, but it's all the preparatory stuff to get to that point that usually takes the time. Certainly the discussions around what's going to be included within the articles, what the rights are going to be, how we're going to work. So you will have to agree, or you need to agree what the articles look like, and potentially shareholders agreements, which were a private document if you want one in place. Next thing, just because you created this entity doesn't mean it's linked to your primary care network. You're going to need to create the contractual link between the two. So what we tend to see at the moment, because it's a requirement under the pension rules, is you have the NHS England pro forma subcontract relevant to PCNs and the network DES, and that creates that link between the two. In essence, it passes down obligations to the limited company, and obviously the staff shift as a result. On the point of staff, we've got to think about potential 2P transfer of staff over. So that will need to be factored in, and the timescales involved. So there's no prescribed timescale in law, but it needs to be as long or in advance as to enable those that are going to be affected to understand the consequences of the shift. So as a general rule, you tend to find it's around 28 days, but these sorts of things need to be factored in. Pensions we talked around, CQC we've talked around, but there are other things. This is going to be a standalone business, so it's going to need to have privacy policies. It's going to have all the data and provisions and agreements in place. It's going to have its own policies and procedures if it's employing staff, so it's employment policies, procedures, insurances, etc. So these things all need to be ticked off, and it goes back to the point of this doesn't happen overnight. So as quickly as we can get these discussions up and running, and these things don't necessarily need to be run sequentially, they can be run, a lot of this stuff alongside each other, the better, because what we can't have is a situation where opportunities land from the centre only for us not to be geared up in readiness to take that. Andrew, anything to add?
I think one of the points, Rob, was this looks like it could potentially be costly for us. But
yeah,
But what we explained to those who we spoke with yesterday was very much it starts with the network members and other organisations coming together to discuss what comes next. So you're not looking at incurring professional charges at that stage. The biggest commitment required is the time investment by those involved. So have those discussions. Rob and I will be on standby for certainly what comes next and how we can help you, but you certainly don't need our input from the get-go. Our input comes later on when you're trying to implement these structures and set those up appropriately, and certainly for what comes next.
Yeah, that's a good point. And I think the point, interestingly, when he said costly, he was more talking around time costs, wasn't he? Interestingly.
Well, it's the whole point of we don't have a huge amount of time where we spend together. We are all extremely busy looking after our patients and looking after our practice. So where do we find the time to be able to do this? And of course, we know that we need to engage with the accountant, Andrew, you, and Rob, the solicitor, and it does take time and effort. So yeah, that was the summary, wasn't it?
It was, but I think everybody left a couple of points really, which were interesting points. So the first point was, that was a sort of a session and a sort of a discussion that needed everybody in the room. That was an interesting one. That the expectation was everybody should have been in that room hearing that, because there are big things happening and people need to be engaged with this. And the other thing is, well, leaving aside the difficulties with this time, etc., it has to happen. So we have to make time. And a lot of the people going away and saying, okay, well, we're going to have these discussions with our, fellow practices, etc., to really start, putting this into a bit of a top gear to move it forward. And I think we reached a Q&A point at that point, and then had to busily try and eat through a mountain of food in the other.
Compliments to the chef.
Yeah, compliments to the chef. But it goes back to the point, if we said, you may well be having those discussions locally. We are on standby if you want to sort of chew the fat on any of this, and get our sort of view as to what might need to be considered or what we might consider to be an appropriate structure. Then do get in touch. But please, the biggest takeaway here is discussions. Let's kick those discussions off, not only locally, but be aware of what's going in a bit more regionally as well. Make sure you're in the room, and because if you're not, as we said before, the danger is that things are going to get imposed on us.
That's great stuff. Thank you, Rob. Always a pleasure to spend some time with you, and I hope the audience today have found that really helpful. Our contact details are on the screen. I wish you a very pleasant day, and thank you very much.
Yeah, thanks all.